Thank you very much for asking me to talk today. By trade, I'm a rheumatologist, so I'll follow on from another physician. I really want to just talk about how we're working together and learning together in more than one way, in a sense. I think HE and CPOC have been cooperating on a number of things recently, and that will be inherent in a lot of the similarities in what we're aiming to achieve. And also, I think learning and working together is a model for how we're providing care for both the patients and populations. And I think, again, you'll find that reflected in some of the things that we'll discuss this morning. So, as we mentioned before, CPOC is a four nations organisation, as it is COPMed. Now, COPMed is as lead dean for COPMed, I represent not only Health Education England, but the other devolved nations as well. So when we're discussing these things, although mentioning HE, I am thinking across a national footprint. So as we described earlier, CPOC has a number of themes, which David went through later, and how we think of that in terms of quality of care is a wider thing about how the outcomes for our patients and populations. And I think there are similarities there with what HE are trying to achieve in terms of how we approach things. We're responsible at HE for the training development of a workforce, and that's through from undergraduate right the way through to our core trainees, higher trainees, coming out with the CCT to provide care on the medical model. But also we're developing existing workforce alongside our commissioners and service providers. And I want to describe a little bit around that from both medical and allied health professional point of view, because this is what HE is about. So we start really by a couple of reflections on COVID and what that's taught us, really. I think we've learned that we can be more nimble in how we manage our services and harvesting technologies for the benefit of patients. And it's shown us that we can deliver our service based on skills rather than necessarily in professional silos we've all been used to. And I think this is brought into focus how we need to have an adaptable and resilient workforce that we care for and we look after the well-being. And clinicians, be they doctors or allied health professionals, must be involved in thinking about the wider health inequalities, population health and health outcomes, which I think will resonate with some of the aims and themes of CPOC. So I think that's a starting point for how we might think of things from now. So I want to talk a little bit about the medical model first, and then perhaps expand into the multidisciplinary angle in this talk. So commissioned before COVID hit us was what's called the HE Future Doctor Report, reflecting on how we might be providing care as clinicians in the future. And it's about training our doctors for the future purpose. And we know that change is inevitable and we must be adaptable to that. This is a picture of us 30 years ago. I'm there with slightly more hair 30 years ago here. And at the time we were students here in this picture, looking ahead, we couldn't really predict the jobs we'd be doing now. But the basics of the job we do are really quite similar. I mean, the drugs and diagnoses and the way we make those diagnoses has changed, but a lot of the basics remain the same. However, looking forward, when we look at the doubling time for medical knowledge, which was at that time 7 years, it's now 70 days. And so looking at a similar group of students today, how can we possibly predict how we will educate and train them in the future? And it's not really no longer a production line of trainees going through the ACP every year in a sort of one-size-fits-all conveyor belt. That doesn't really suit the way we should be educating and training. And we need to think again about how we do that. And hence the Future Doctor report has come out to help us reflect on that. Some of the themes we've already talked about is around the increase in frailty and multimorbidities, and as Jerry's described, around the way we should optimize our care for patients with diabetes. Also, we talked earlier about anemia and frailty are really important things to consider when we're thinking about optimizing patients for surgery. And the Future Doctor reflects on the place of the doctor within a growing multidisciplinary team, and enhancing technologies, IT, biotechnologies, genomics, and all of these other important things that will play a part in the way we should train our doctors. So I'd like now to just reflect a little bit on the key themes that the Future Doctor report provided, and link some of these to the objectives and themes that CPOC have, which I think you'll see is that synergy there. Research and innovation is a key theme. Technology, I think, as you might imagine, perioperative care provides almost a natural testbed for a lot of initiatives, maybe electronic consent, patient information, health coaching, prehabilitation, and how can we enhance technologies to make that work? And that's reflected in the way we should be training. The multidisciplinary team, I shall talk a lot about more in a moment, as well as leadership and fellowship. But the patient-doctor relationship has changed, I think, for the better. Patients are much more involved in their decisions. I think the recent events have brought into sharp focus, how important compassion and spending time, making those relationships with a patient are. And when you can't provide that with the challenges of COVID, sometimes at a distance with patients and their relatives, it is challenging. But that shared decision-making between professionals, patients, and their carers is really important when we're optimizing surgical pathways or any pathways to do the best for our patients. And throughout all this, we should, of course, be professional. And professionalism is really embedded into curricula as part of general professional capabilities that have been embedded into all postgraduate curricula now. And I'm sure will be reflected in the way that we continue to train. Another thing which is important is providing for health needs in communities and different populations, and providing care in remote and rural settings, for example, in patient homes, and reducing inequalities of access is important. And that again reflects again on how we optimize the care before. And I like David's description of a preparation rather than waiting list. And that really makes us think about how we should be interested in looking after our populations. I'll talk in a moment about the concept of what we call the T-shaped doctor, or the specialist and generalist, to managing complex comorbidities, and I think that has resonance in the perioperative care sphere as well. But one of the things again that I think COVID has brought into sharp focus is that need for us to have a flexible approach for our clinicians, so they have lifelong fulfilling careers, and making sure the workforce feel valued and their wishes are incorporated into how we should promote careers. Okay, just look at a little bit about this concept of the extensivist or generalist, if you like, and the expertise. This idea of producing a broad range of generalist skills for our doctors of the future, and that everyone should have within their sphere, but also having the opportunity to develop that special interest as well in a deep area, but not losing sight of that holistic picture, so that we're not focusing on diseases. We're focusing on managing that broader aspect of the patient, making decisions with their frailty, comorbidities in mind. And we mentioned making every contact count earlier on, and I think that really is what we're treating right from foundation and from our medical student level, making sure that every contact with that patient is an opportunity to make a difference and prepare them for anything or to prepare them for as they get older, to make sure that they're more healthy, or they're going to face challenges such as surgery. So why not think about your orthopedic surgeon who specializing in redo surgery, being, talking to patients about their obesity, about other health issues, diabetes, their anemia, and making sure they look after the wider concept of the disease within the context of the population that the patient lives in as well. So moving on a little bit, as I say, HEE and central to the way we're going to implement a lot of the themes of CPOC, we need to think about how we're going to manage this within a multi-professional environment. And it's delivering care on the basis of expertise and skills that people have, rather than the professional labels that people possess. So we need to think about a lot of new roles that are emerging and how this is going to fit into the puzzle. And not only that, but also how we supervise, how we assess, how we develop people within these new roles. And that may involve working and learning together with interprofessional learning. And we need to think about, when we're devising programs for teaching, for training, for our undergraduates and postgraduates, how that might happen with the professional group rather than just added on. So how do we learn together? And I think, as I say, the way we're thinking about perioperative care with that workforce is important, to think about what are the things in curricula that are common, what are the things that people can actually deliver together, and build it in from the start rather than just tacking it on. There's a bewildering number of professionals that are emerging. And some of these you may not have even heard of. I'm not quite sure what an epigenetic counselor is, but apparently they exist, and we need to understand what they can do, and also, just as importantly, what the limits of what they are, what they can provide, and translate this into a version of what they can provide for patients within the team. And that's going to be important to make sure we're making full use of all these emerging professions, as well as those that are perhaps more traditionally that we work together with, which I'm going to talk a little bit more about now. When I was looking into this, it struck me there are a lot of stakeholders in different professions that we need to understand and work together with. And there's, I think, the way in which HEE and the other statutory educational bodies can work with CPOC is navigating that complexity. Royal College is, of course, involved in this as well, and I think that can add to the complexity, but also is an opportunity for us to make sure we're looking at the way in which we start with a patient, we start with a service need, we start with population, and then we marry up the type of professionals we need to deliver that care, focusing on this model. So one group that really has emerged is advanced clinical practitioners, or ACPs. Now this is being overseen by a national group, Centre for Advancing Practice, and various master's courses are emerging through HEIs for credentialing these, based with a standard portfolio. And the idea is there will be a directory of advanced care practitioners that they'll be regulated by their parent profession, be it nursing, be it physiotherapy or whatever. But this is an emerging group of practitioners that we need to embrace as part of our workforce. They have a high degree of autonomy and involved in complex decision making, and they're really a development on the existing advanced nurse practitioner, and it for example, and this is going to be a really important part of the workforce that we need to make sure we look at. Then there's another group, the medical associate professions, or MAPs, which includes, you'll be familiar with PAs and PAAs, and also our surgical care practitioners and the new advanced clinical critical care practitioners. So we need to be able to profile how these how this workforce might, you know, at a LEP level, how that group will work within providing perioperative care. This group is not regulated currently by the GMC, but that is under review. And for example, with physicians associates, the Royal College of Physicians are very much involved in doing that, and their curricula are being developed. And I know, working with the Royal College of Anaesthetics, that we're doing quite a lot of work with anaesthetic associates at the moment in finalising that curriculum. A lot of it maps across actually from the curriculum for anaesthetics, the training programme for our postgraduates. So you can see a lot of similarities in the way which we not only work together but train together there. Then there's a separate group, the surgical advanced clinical practitioners, which were developed in a sense in conjunction with the Royal College of Surgeons, the Royal Colleges of Surgeons, in response to improving surgical training. And this is about supporting the workforce to allow our trainees to access more theatre time and to develop. And it's mainly focusing on both elective and emergency inpatient management. So not just, you know, necessarily working in the theatre, but also it's more around those things that go around to facilitate that theatre time. So you can see how that would be a really important group to work with when we're thinking about perioperative care. And there is an online session planned, a date to be confirmed yet, with HCI's employers and ACPs. And I would recommend, if we're not already involved with that, with CPOC, that will be a very important strand of professional that we should be looking at in terms of where we're going to put them as a workforce and how we train them. This really all puts in the concept of the extended surgical team, which currently is being piloted at a number of trusts. And there are a number of outcomes we're looking for as part of a study there, looking at, you know, improving clinical activity and enhancing surgical training, as well as, you know, making sure that teams are stable and patient experience and outcomes are good. And all of these things you can see are reflected in the aims of CPOC too. A little bit about leadership and followership. This is something that is not an add-on. It should be incorporated into our programs, so that we know, you know, we can make sure that people understand their position within that structure and work and learn in a team. So, for example, when you're setting up a service, for example, you know, GI surgery, for example, we need to train our trainers and our leaders for the future, so they understand the challenges, the wider challenges of that, and what are the screening implications, prevention, the nutrition, the stoma care, all the things in the community that need to be set up need to be appreciated so that that team can work together. So I just want to briefly mention a little bit about how workforce is being managed at a sort of a higher level. And I couldn't go without talking about the NHS People Plan. It was published in July last year, and HE and HSEI were involved with that. And one of the themes is really the challenge of the workforce and having enough staff. And it's not just about commissioning more staff where the service is required. It's looking how we recruit, how we train, how we keep our workforce, and how we welcome back colleagues who want to return to the workplace. And that's about looking after our staff as well and their well-being. And that's really become central in what has been published in the NHS People Plan. So employers and systems have been asked to implement this, and there are a series of local people plans that have been developed as a response to this national plan, and so-called people boards have been set up, which HEE sit on, as well as employers and ICSs to develop that. And I think when we're talking about such a large chunk of how within perioperative care, we need to make sure that that is represented in how we're planning those services. And HE are very much involved in workforce transformation and how we can improve recruitment, retention, and analyze what the workforce needs are to inform people plans. And that flexibility and adaptability of the workforce is really important. I'm just reflecting back finally really about how perioperative care pathways make better use of resources. And it's about that multidisciplinary working and clearly described as before that prehabilitation, rehabilitation, and clear pathways for how we manage perioperative care. So just to summarize at the end, really, how are CPOC and HE working together at the moment? Well, it's evidently cross-organizational. We need to think about reducing the silos and working in that multidisciplinary way. We need to link with a large number of stakeholders, and we mentioned how the colleges are involved, NHS and I, employers and ICSs. And through that, we will develop the curricula. We'll get through the challenge at the moment of recovering from COVID and making sure that we can not only make sure that the patients are cared for and that we catch up on waiting lists, but also that we catch up on their education and training as well. And this is an opportunity for a CPOC to come to the fore in assisting with that process, with all the training that has been held up by the COVID pandemic. So just a final slide, really, an example of how CPOC and HE have been sharing some of their goals recently. We're looking at a perioperative credential with the GMC in providing a recognition and a registration, if you like, of the perioperative care. The different staff with different specialist skills, we need to define how they will fit into that perioperative pathway. But it's a way of formalizing a curriculum and making the best use of people's knowledge and skills, whatever part of the workforce they come from. So thank you very much. I hope to answer questions as part of the panel later on, but thank you.